Okay, we started the registration. Please, Stefania goes.
Well, hi, welcome everybody. I am Stefania Di Fusco, cardiologist at the cardiology unit of San Filippo Neri Hospital in Rome, and the current AMCO Young Working Group Chair. I am very glad to introduce this second webinar of the Medical Statistics Minicourse created and conceived by PINK International Young Academy of Cardiology, a subgroup of IAC. We are very glad to have with us Sara Moscatelli, coordinator of PINK IAC, and Professor 2.IYAC founder. I want to thank them for realizing this mini course. This is the second of a number of webinars on medical statistics aimed at giving a basic primer on statistics knowledge to interpret and critically apply scientific studies. Before starting the webinar, I remind all the attendees to mute their microphone and only ask questions in the chat. Now I am very delighted to present Professor Giuseppe Biondi Zoccai. Since 2011, he has served as assistant professor medical, surgical and science and biotechnologies of the Sapienza University of Rome. He is editor-in-chief of Minerva Cardiology medical journal, and he serves on the editorial board of several biomedical journals. Professor Zoccai has edited several textbooks, ranging in topics from network meta-analysis to umbrella reviews. So I am sure that, such as the first webinar, it will be a very interesting experience for all of us. Now I will pass the microphone to him. Hi.
This is Giuseppe Biondi Zoccai. Thank you, Stefania, for presenting me. It's a pleasure to be here. I think it's a very key effort at teaching and fostering an approach to lifelong learning, and especially focusing on methods. Without further ado, but thank you again for this opportunity to be here and learn and discuss constructively with other experts these topics. I want to introduce you my esteemed colleague, Professor İltan Boga from the Nizamtazi University in Istanbul. He's both a professor of cardiology and a professor of biostatistics, so he has the perfect expertise combining two different disciplines, which are, however, so important in current research and clinical practice. His work is focused on several domains, but including risk predictions and the importance to have a closer and detailed look at, for example, scores to predict or improve decision making. Please, Professor Tamboga, I leave the word to you.
Thank you, Professor Giuseppe. Thank you for your kind words. It is a pleasure to be involved in this meeting. I believe this will be useful for all participants. As you know, many of us think that the statistics is a nightmare, but I think in this two presentation, our colleagues will make statistics more easier and understandable. Now I would like to introduce to our first presenter, Dr. Camilla Calvieri. She's imaging cardiologist and assistant professor of cardiology at University of Rome La Sapienza. Yes, now I'm going to hand over to Dr. Camilla. Yes, Dr. Camilla, please.
Hello, everyone. Thank you for kindly inviting me to participate in this event. I will speak about choosing the correct statistical test. But we have to start from the basis. A statistical test is useful to determine whether a predictor variable has a significant relationship with an outcome variable and to estimate the difference between two or more groups. All statistical tests start from a null hypothesis of no relationship or no difference between groups, and they evaluate if the observed data fall outside of the range of values predicted by the null hypothesis. As you can see in this picture, this is the basis of the hypothesis testing. But a statistical test gives you a number that describes how much the relationship between your variable in your test differs from the null hypothesis of no relationship, and it calculates a p-value, that is a probability value, and we can use different thresholds or alpha value, always chosen by a researcher. The most commonly used is a p-value below 0.05, which means that the data are likely to occur less than 5% of the time under the null hypothesis. P-values are usually automatically calculated by your statistical program and can also be estimated using p-value tables. P-value or probability value tells you how likely it is that your data could have occurred under the null hypothesis. How do you calculate the p-value? You can use the tables of your statistical software based on the degrees of freedom that are number of observations minus number of independent variables. And this table shows you how frequently you would expect to see that statistical test is under the null hypothesis. P-value can only tell you whether or not the null hypothesis is supported, but the number of independent variables you include in your statistical test tell you how large or small the statistical test needs to be to generate the same p-value. In every scientific report, you have to report to describe exact p-value for statistical tests rather than using symbols to denote significance categories such as p below 0.10. And generally, very low p-values are accompanied by point estimates of effects and the confidence interval that are typically reported as below 0.001. In other cases, a greater level of precision is called for because of the chosen significance levels or correction for multiple testing. Before to perform a statistical test, you have to view your data that have to be collected in a statistically valid manner, or through an experiment or through observation made using probability sampling methods. The most important thing is that your sample size needs to be large enough to approximate the true distribution of the population studied. Every statistical test is based on two main aspects: statistical assumption and types of variables. Statistical assumptions are fundamentally three. The first one is independence of observation. That means that your observation or variables included in your test are not related to each one. The second one is homogeneity of variance. That means that variance within each group compared is similar among all groups. And the last one of the most important of this, is normality of data. That means that data follow a normal distribution, often represented by a bell curve. This is a graphical representation that shows you that 95% of the data fall within 2 standard deviations of the mean. But if your data do not meet the assumption of normality or homogeneity of variance, you have to choose a non-parametric test. Whereas if your data do not meet the assumption of independence of observation, you have to use a repeated measure test. The statistical test used to know if your distribution of data is normally distributed or not is a Kolmogorov-Smirnov statistical test. And the p-value given by this test tell you if your distribution of data differs significantly from a normal distribution. As you can see in this picture, in blue are data normally distributed, and in red are data not normally distributed. The other important aspect about your statistical test is the type of variable that you can use, because we have principally two groups of variables, quantitative variable and categorical variable. As you can see in this picture, quantitative variables are divided in continuous variables such as height, weight, age, or discrete quantitative variable, whereas categorical variables are divided in ordinal, nominal, or binary variable. And then you have to choose your predictor variable, so as called independent variable, and your outcome or output variables, also called dependent variables. Variable selection approach is very important during the choice of your statistical test. In fact, variables can be chosen by expert opinion by pre-specifying the exact predictors to be considered, and generally is used a stepwise method that relies on statistical criteria used to select optimal covariate for the model. For example, ordinal variables with a small number of values can be categorized or this is generally be avoided for continuous variable or ordinal data with a wide range of value. How you have to choose a non-parametric test or a parametric test. A parametric test is based on parameters such as mean and standard deviation, and you can use it when your variable of interest is continuous and normally distributed. In all other cases, you have to prefer a non-parametric test that are based on ranks of observation, not on their real value. But as a general rule, if the number of observations is less than 20, a parametric test should be avoided. The easy cases in which you should definitely select a non-parametric test are the outcome are when the outcome is a rank or a score and the population is clearly not Gaussian, when some values are half the scale, that is too high or too low to measure, and when data are measurement and you are sure that the population is not distributed in a Gaussian manner. Among parametric tests, the most used tests are comparison of means, and the first one are t-tests that are used when comparing the means of precisely two groups, continuous variable groups normally distributed, and MANOVA and ANOVA that are tests used to compare the means of more than two groups. This is a rapid flowchart to start from an hypothesis testing and then choose between parametric and non-parametric tests and the exact statistical test to use on the basis of how many variables and how type of variable do you have. Correlation tests are used when you have to evaluate the association between variables, and the mostly used are Pearson correlation and Spearman correlation. Pearson correlation is used when you have to measure the association of two continuous normally distributed variables, whereas Spearman correlation is used when you have to evaluate the association between two ordinal variables or variables not normally distributed. And finally, these are a graphical representation of correlation. Chi-square instead is used to measure the association between two categorical variables. So this is an example of the production of your statistical software. Fisher exact test is the best choice because it gives you the exact p-value, whereas chi-square gives you only approximate p-value. In general, you have to definitely avoid chi-square when the number in the contingency table are very small, whereas when the numbers in the contingency table are larger, the p-value reported by chi-square and Fisher test will be very similar. In other cases, you can also use Yates continuity correction to apply to your chi-square test. And then regression tests that measure cause and effect relationship between your variable are mainly divided by simple linear regression, multiple linear regression, and logistic regression. The first one measures how a change in the predictor variable predicts the level of change in the outcome variable. Multiple linear regression measure how changes in the combination of two or more predictor variables predict the level of change in the outcome variable, whereas logistic regression is used to describe, to explain the relationship between one dependent, usually binary variable, and one or more nominal, ordinal, interval, or ratio level independent variables. This is a graphic representation of simple linear regression analysis. But the most important thing when you use correlation or regression tests is that your observations are independent. In fact, ignoring the dependence in the analysis of correlated data tends to downwardly bias error variance estimates and inflates the risk of false positive results. Covariable adjustment is another point very important when you have to perform your statistical tests. Multivariable regression is often used to contrast outcome between more than two groups. It is applicable to both randomized and non-randomized design and more commonly used in observational studies. In randomized trial, covariable adjustment may be useful for several reasons. Among non-parametric tests, we have the most commonly used, such as Mann-Whitney test, Wilcoxon test for paired samples, Kruskal-Wallis test, and Friedman test. The first one is called differently, and it is useful when you want to know if your group is different on your variable of interest, and your variable is continuous, is not normally distributed. You have only two groups, and you have independent sample size. The independent sample. In fact, you have to compare the median between two independent groups. Wilcoxon for paired sample is used when you have two observations from a single group on your variable of interest. The characteristic is that pair samples means that your two groups consist of data from the same group observed at multiple points in time. Obviously, your variable is not normally distributed, and this could be a graphical representation of a Wilcoxon pair sample test. You can use Kruskal-Wallis one-way ANOVA if you have many groups different on your variable of interest, and obviously your variable is continuous, is not normally distributed, and you have three or more groups independent from each other. What about Friedman test? Friedman test is used when you want to know if many groups are different on your variable of interest with a continuous variable not normally distributed and related sample repeated measure from the same unit of observation. This is a rapid flowchart to compare. On the left side, you can find the not normal or non-parametric test compared to normal parametric or parametric test on the right side. You can see that every non-parametric test has a correspective parametric test on the basis of the type of variable and the number of variables considered in your statistical test. It is another flowchart very useful to decide what is the best statistical test for your data. You start from to choose your predictor variable, and on the basis of the type of your outcome variable and of the number of variables do you have, you can have the exact statistical test to use. Among survival analysis, primary endpoints are the most important aspect to specify in general in scientific reports in cardiovascular medicine. Mortality or occurrence of major cardiovascular events are primary or secondary endpoints. In general, endpoints are analyzed with techniques referred to as survival analysis, appropriate for time to event data, and account for censoring. In your scientific report, you have to specify the total number of participants at risk at the beginning of the study, and then to define what constitutes an event in the analysis, the total number of events that occurred during the study follow-up, and finally the time at which participants are considered a risk for the event. This is an example because Kaplan-Meier curve survival is a non-parametric estimator, and as you can see in this graphic, you have a group column, a time column, an endpoint column that in your statistical software are inserted in different points to finally have this two distribution of groups, and according to number at risk and to the period of your study. In Kaplan-Meier, in survival analysis data, one important point is censored data. Observations are called censored when the information about their survival time is incomplete. A patient who does not experience the event of interest for the duration of the study is said to be right censored. The survival time for this patient is considered to be at least as long as the duration of the study. In other words, censored data is a type of missing data, and we can have a small data set with very large distance between curves, or we can have a large data set with a more accurate difference of median of different curve analysis. Censored data can affect substantially Kaplan-Meier curve, but have to be included when fitting the model. So be cautious when interpreting the end of Kaplan-Meier, especially near the end of the study. The height of the drop can inform you about the number of patients at risk, even when it's not reported or when there are no confidence intervals shown. Thank you for your listening.
Thank you for your excellent presentation, Dr. Camila. I think we can proceed to the next presentation.
Yes, Camilla, can you stop to share your screen? Perfect. Hi, everyone. I would like to thank the Pink International Young Academy of Cardiology for the invitation and for this great initiative. It's a great pleasure to talk with you about data collection and data management. To begin with this it's important to resituate the relevance of data collection in your time, for what purpose, why in this time period, and what resources are available. In practice, what impact? In the same way as human evolution, we are currently experiencing an evolution of algorithm. We nowadays experiencing an increase of storage of capability hardware. On the right, you have the European Organization for Nuclear Research. In one of the largest and more prestigious scientific laboratories in the world, level 0 of these grind processes, over 1 million calculations per day. So it's a huge modification of technology. And so now we have the possibility for every scientist to use these tools. So the promise of the big data analytics and artificial intelligence is to bring new insights to the medicine. Multidimensional data is a common issue. Use data from different databases is enabled by patient identification. So the data linkage allows the centralization of data and the analysis of different dimensions of the same patients. Here, for example, you have the activity data, blood product, and pathologies are centralized. The heterogeneity and the granularity of the data brings great strength and power to the analysis and algorithm. So the implantation of innovative analysis within the type of large-scale structure reflects the translational research. Here, we are talking about electronic data files. So one of the base of the data collection is the electronic medical record, based on cooperation, protection, and use for research. In many countries, such as France, this record has the priority of the states. And many experts report and recommend the general use of electronic medical records. Unfortunately, in many countries, like in France, but such as the United States, the generalization of electronic medical records is still difficult. As you can see here, there is only a half of population who use the electronic files. So database quality, why are we talking of this and why it is very important? Because as you can see here, the database quality is the basis for every approach, and especially for machine learning approach for unsupervised analysis. And the good example of this, it's IBM Watson. I am sure that you all heard about IBM Watson, and it's maybe overpromised and undelivered on IA, artificial intelligence, healthcare. After its triumph on Jeopardy, you know, it's a huge TV show in US, IBM Watson seems to not revolutionize the medicine. So doctors still waiting. So the data collection is the key. The data collection is the base. And if you don't have any data, you can't use complicated algorithm like IBM Watson. So data collection, before data collection, you have to think about few things. Define your goal, define your source of information, define your collection technique, automated or manual. And one of my tips is to limit data collection to your specific issue. So data collection issue are data quality, standardization of data collection between centers, reduction of missing data, and possibility to propose correction queries customized by center. So you send a different message for every investigator. So the step one is to identify data elements needed for your specific project. What data, what information, what question do you want from the project? And after, what is the scope of your project? Geographic, time frame, population, disease. Step two is to identify potential source for needed data. Source close to the data, reliability of the data, data security, of course, because it's health data, and manual or automatic extraction. Clinical data capture, so it's a classic things for every physician. So who collects the data and how it's possible to do a manual data extraction? At first, it's clinicians when they assess, diagnose, or treat patients who are participating in a trial. You have also trial research assistants who help you. And so there is several software options for the collection and management of health records. Electronic data capture is also possible. You know that we can collect data using mobile phone application. So it's quite common, it's quite cheap, and it's a large network. Information collected remotely, repeated, and also with different capture. There is many programs that can capture simple text message, interactive voice response, or self-administered questionnaire. We see a lot of this new interface with the COVID crisis, the COVID-19. So all the data are centralized and the data are stored directly in a central database. And so you can immediately processing this data. But what is a more practice for you? It's maybe the old and well-known spreadsheet Excel. So what is the benefits and disadvantage of Excel sheet? The benefits are clearly the easy to access, easy to use, freedom to take notes, and possibility to have an overview for a small number of patients. The disadvantage, if you want to do a multi-center study, there is no data quality control, you know, and there is a risk of failing in errors and no data protection. So I want to talk to you about the system that I use. It's a Red Cat system. It's an example of program for multi-center data collection. It's dedicated for academic center, but there is a lot of system like this, but this is one example. So the benefit is data control quality, limited risk of failing in errors, data protection, of course, personal access for every participant. So you have a traceability for every investigator, and you can personalize of queries. The disadvantage that it requires an appropriate training, dedicate only for academic center, as I said. There is also a technical, we need a technical support for the platform weaknesses and administrative process for data security. As you can see, the system does not store all the data and possibility to see each patient. So you see here the whole ID. There is also tools like data visualization systems, allow data management to be start during the study. So you can start your data management and identify your outlier easily during your study. So you can see here, you have creatinine levels, maybe outliers, and maybe you can call the investigator where is this patient? So we can assess the quality of the data collection, send rectification to the investigator, and this is a audit tools, and it's a very common tools. So you see that during the data collection, you can begin the data management, but what is the data management? The data management, I think it's very important to see the 5V of the big data. Okay, so when you do data management, you aim to do a volume, veracity, velocity, variety, and value of your data. And in light of the evolution of data governance, that's clear that there is a 6 essential characteristic of this concept with virtue. So data management represents different steps. So at the beginning, you have the data collection, maybe the more executive data collection as planned. After you cleaning your data, you prepare your data. Sometimes you have to transform your data. And if necessary, for missing data or inconsistency, you can revisit previous step. And after, and only after, you can do data analysis. Alors, step by step, what can we do for data management of delay variable? That's quite tricky. I advise you to use numeric variables for delay, rather by alphanumeric variables in particular, because that's less space in terms of memory, and only numeric variables are taken in count by certain analysis, as we can see before with the previous topic. So it's important for you to modify until the beginning the display format of the date in the database to use repeated data. Another tool very used is the data dictionary. Data dictionary, it's a database reference. It's an interface between the statisticians and the clinician. Maximum number of variables are available and minimum number of modalities required per variables. So you have the name, the modality, the significations of each modality, and you can also put remarks for everyone. After, there is a quality control. So before analysis, it's essential to clean the database. So it requires to go through several steps. So we see every steps. So to identification the duplicates, identification the inconsistency between variables, the proportion of missing data, and identification also the individuals for whom there is outlier. So let's begin with the duplicate. So there is 3 types of duplicates. There is duplicate, real duplicate at all points. There is a duplicate, but for which there is there are incomplete data for the line concerned. The line is the patient. And there is also duplicate, indicating that when you see at the first place, at the first look, there is different subjects. So for this different diagnosis of a duplicate, you have different answers. So you can complete your database, or you can delete one of the lines, so you can delete one of the patients. But be prudent to delete before to delete patients. After, you have to manage the inconsistency. So a study involves a large number of variables. So that is why it's important to check the consistency of data between these different variables. So an example will be considered as inconsistent data, any date of hospitalization reported without hospitalization, or any pregnant man. After, you have to manage the missing data. So that's kind of tricky also, because the presence of missing data can have important repercussion in the interpretation of the result. This is why this is important to identify and complete them. This may concern either variable as a whole or individuals. So management of missing data, each situation requires a specific response. In the first case, you can delete variables if you consider that the proportion of missing data is so much important for these variables. So you have to look variables by variables. And after, for the missing data, you have also to look patient by patient. So in this case, it's possible to delete patient with many missing data. But be careful, everything depends again of the number of the subject. And be careful to not systematically exclude patients. Okay, so I advise you to do every time a sensitivity analysis for the initial database and the final database to be sure that you have the same conclusion. And so one good tool to deal with the missing data, it's imputation. So imputation, missing data, it's simply replacing these values. In some cases, very simple methods can be implemented. For categorical variables, replacement by the dominant values, like the most frequent. For numerical variables, replacement with the global mean or the mean per class. Be careful, this is a very most popular method, but it's rarely a viable solution. So many techniques rely on the other variables, including the unsupervised algorithm, like machine learning. So we could be a webinar on this topic. It's very deep and there is a lot of possibility. So think about always the meaning of the missing data. If there no meaning to this absence of data, perhaps this deserves the creation of new category of variables. So you have to transform your database. And always quality control. So you have to do general sensitivity analysis of the non-computed data set. So you have to compare the initial data set and the imputed data set to be sure that you have the same conclusion, and generate several imputed data sets with confidence intervals. So you can generate many data sets with imputed data. And at the end, you can calculate the confidence interval for your test. And for finish, the outlier management. So it's case-by-case basis. The outlier may be associated with potential false value. So you have to ask your investigator and to check patient by patient. Thank you again for your attention, and do not hesitate to ask your question on the chat. Thank you.
So maybe we can have some room for the discussion and the comments. If there are no questions from the audience, we would like to introduce you to two experts which will discuss these presentations. One is Dr. Giuseppe Ciliberti, who is a leading cardiovascular expert with general and arrhythmias expertise, practicing in the University Hospital of Ospedale Riuniti in Ancona, who has broad research interests, including myocardial infarction, coronary spasm, sudden death, cardiomyopathies, and who can capitalize on data science for these research interests. So, Dr. Ciliberti, please, if you want to comment on one or both the presentations.
Thank you, Professor Zoccai, for the nice presentation, and thank you to Dr. Sara Moscatelli and Dr. Stefania Di Fusco for the kind invitation to this impressive webinar. I would like to congratulate the speakers for their very comprehensive presentations. And I just want to start with a question to Dr. Camilla Calvieri. And my question is a very simple question. You know, at the beginning of the career as a researcher, also if we are clinicians but not statisticians, we have to deal with some basic issue. One of these is which package to begin with. You know, for example, SPSS rather than Stata, and so on. Dr. Calvieri.
Yes, thank you for your question. In my experience, I began with SPSS, then Stata, and then I went deeper with our studio or our program. But I think that for a clinician is more simple to start with SPSS.
Okay. Thank you for the answer. And I have another question to Dr. Bonnet. What in your experience, what is the how can we define the difference between a flat file database versus a relational file database?
Thank you, Giuseppe, for this very good question. So as we see during the presentation, there is data linkage. So flat file database stores data in a single table structure. So it's a unique and single data set. And a relation data use multiple table structure, cross-link referencing record between tables. So the flat files database, it's unique, and a relational files database, it's a data linkage. So you have a link between the data set. So it's important to organize this, this synchronization with a good identification of patients. That's not so easy between the database.
We may now have Professor Tamboga introduce the other discussant of the session. So Professor Tamboga, if you want to introduce Dr. Birkholzer.
Yes, Dr. Sara Birkholzer, our another discussant. Do you have any question to our presenter?
Yes, thank you very much. Thank you both for a fabulous presentation. I wish I had that many years ago. It makes so much more sense now having listened to both of your talks. So thank you very much. And my first question goes to Camilla, and I wondered whether there are any sort of reporting guidelines for statistical analysis.
Yeah. There are the American Heart Association guidelines that I have used for some statistical concept of my presentation, and are very useful to have a flow chart to write a scientific report. Yeah.
Thank you. And a question to both of you. I don't know who wants to go first. It's not. It shouldn't sort of provoke antagonizing clinicians and statisticians, but should we be one or the other, or should we be one in one person? What do you think? What results in their best outcome? Should we all aspire to acquire the maximum knowledge and become statistician, or should we just leave it to the expert?
It's a quite provocative question, Sarah. So I am perhaps not the best placed because I stopped my clinical activity for 3 years in order to do a science thesis in epidemiology, in a unit reach, in methodologists, engineers, and mathematicians. So clearly, I think that the union is the force, like always. And it's clear that the statistical tools is not an end in itself. And there is always a trade-off between the clinician sense and the data. But, you know, like one of my cheats said, the best methodology is the way to go to the true message. And there is not one true message. So you have to go with the methodology and to discuss with other specialty, but not just in medicine, but also engineers and other specialty. And that's very rich for you and for you. So I think that union is the best.
And I guess that's why we're all here. Is there anything you wanted to add, Camilla? Otherwise, there are some questions in the chat also.
Yeah, I agree. For me, the best situation is to be at the same time clinician and statistician, but there are some complex analysis, so it would be useful to discuss with a statistician for the more complex analysis. But for a clinician who wants to do a research career or to write a scientific report, it's fundamental to have some statistical concept useful to interpret the data.
Thank you.
Thank you.
There also is a question in the chat, I think, from Aisha about how much missing data is sort of acceptable. Is that something you want to comment on?
Yeah. I try to answer in the chat. So it's a very hard question because there is no clearly recommendation and guideline for this. That clearly depends on the database. For me, I think that when you have half of your variable missing, I think it's very hard to do imputation. But if your dataset is very completed, and if you have a lot of granularity, and if you have a lot of variables available, I think that now with the new tool of imputation, you know, you can use, by example, a random forest imputation. It's clearly very strong. And so you can impute maybe 10 or 50 virtual databases. So even if you have 1/3 of modality not available, you can impute it, and I think it's quite correct. And at the end, there is no clearly threshold, but when the good things all the time is to do a sensitivity analysis. If when you practice a sensitivity analysis, you see the same results, that put a good strength and robustness of your results. I'm not sure I clearly answer to everything, but I think that you have every time to check with different data sets.
Thank you. Hopefully, Aisha, that answered your question. All right.
So I think that the session is very interesting. So what would be, this is a question for everyone who is participating, what would be your advice for the first resource to learn more? A journal, a book, a website, and which of, specifically, which one of them? So, I mean, should I start now by studying a given book or a website or YouTube lectures, what would be your first resource now to further study this topic? Sarah, you can begin if you want.
Yeah, Sarah, maybe you can begin, or me.
As you please.
Girls first, you know.
Yeah, definitely.
Sorry, was that question directed to me?
To everybody. I mean, I would like to know, now I'm shutting off the computer. Where should I go? Should I go to a book, to YouTube? Should I buy, for example, 1 month access to a website dedicated to statistics? Should I go to a course? What would be my first choice now to further learn these topics?
I can answer to the question. Okay, thank you. In my experience, it has been useful to participate in statistical courses and to follow website and to study in dedicated books, and also to discuss my results with other more expert statisticians.
Yeah, sure. I'm clearly in that way. I think it's very important, even if it's virtual, even if it's not in face-to-face, to meet people, to see one guy who explain you. I think that it's the best way, with example, with a concrete example. But also when you begin to code, when you begin to practice Stata or RStudio, all the time I am looking for in Google or in the forum. So now I'm used to when I am blocked on a line, I'm used to go on the web to search why that's doesn't work. You know what I mean? So it's very collaborative way of thinking to do statistical. I see this like this, like a collaborative work.
I agree with you, Guillaume.
I see. If I may, one of the biggest discoveries in my career was that any given statistician was not all-knowing. So one of the strengths of a professional statistician is that he knows exactly what he doesn't know. For instance, I remember going to a statistician because I needed a Bayesian analysis, and he told me, I'm not an expert, I won't do it. So I think it's crucial to know what you can do and what you cannot do, and recognize that some stuff can be done by you and something else by other people. I think a good example is like a clinical practice. If I'm good at echo, I can take charge of echo. But if I'm not good at, say, MRI, I need to go to somebody who's an expert in MRI. And that's the key point. It's like a chain with many links. I don't know if you agree with this.
Yes, I totally agree with you.
Yeah, like in medicine, methodological and statistician have a different specialty. And now with machine learning, intelligence artificial, you have a lot of different specialty. So the most dangerous thing is to do things that you don't know. It's like in medicine. So I'm totally agree with you, Giuseppe. It's a great message.
Fantastic. Shall we have Sarah to wrap up and conclude? Is Sarah there?
Me? Okay. I'm just want to share my slide. I hope that you can see it. It's a bit easy. So, okay. No, sorry for a not perfect showing of these last slides. Basically, I will just activate my video. I really would like to thank you everybody for the participation in this second webinar of the Pink IYAC ladies. Particularly the male presence has been very great example of he for she, and I really appreciate it. So thank you very much. I would like just to take these last 2 seconds of the webinar to tell you that the course is not finished, and we're gonna have 2 other webinars in September. You can see the title here in the slide that I try to project. So reporting and interpreting the analysis and meta-analyzing clinical research. So keep an eye on our websites, in particular the IYAC one and also the social accounts. As have been already said in the chat, the webinar has been registered. And so you're gonna find it in very easily in the YouTube channel of IYAC. And for me, it's everything. So if the moderator just want to say final greeting, I'm happy to. Okay, so thanks again very much. And I think we can conclude, and let's wait for the new appointments in the future. And thanks again to Tukbad that has really helped in the organization of this, and Stefania Di Fusco, the coordinator, that unfortunately I believe has some with the course itself. Thank you.
Thank you all for the presence and see you to the next webinar.
Thank you all. Bye-bye.
Thank you all. Bye-bye.
Bye.
Bye.